Thank you for joining me for this short module on adjusting insulin in peritoneal dialysis. I want to acknowledge with gratitude that we're meeting today on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank them for their stewardship over these many years. So we'll talk about the key considerations for insulin adjustment and outline decisions if insulin is administered subcutaneously or if it's administered intraperitoneally, and talk about the practical adjustment steps. So the problem is that A1C in patients with renal impairment is not as accurate as we would like because they often have a low hemoglobin level. And because A1C is a measure of the amount of glucose that's attached to the hemoglobin, it can't be measured perfectly, and it often reads lower than what is actually evident in the glucose levels. So rapid shifting, fluid shifting can also impact the accuracy of the interstitial fluid result, which is where we measure on continuous glucose monitors. And as the rapid shifting occurs in both hemodialysis and peritoneal dialysis, CGM has not been approved for use without checking point of care blood glucose result to make treatment decisions. However, we do know people wear them, and they might wear them for the glucose trends, but we'll chat a little bit further about that later. So key considerations are making sure that this is an individualized approach. There is no one set amount of insulin. You can say that if they're on a dialysate of 2.5, that it's going to be this amount of insulin. Every patient is unique. They have different blood glucose patterns. They have different stressors. They may have steroids on board for other issues. And the type of PD that they're using as well makes a difference if it's continuous ambulatory peritoneal dialysis or automated peritoneal dialysis overnight. So PD dialysate contains glucose, which is the premise behind it, is that it's supposed to take the toxins and then excrete them. And because that's absorbed into the bloodstream, that increases the glucose levels and it raises the insulin requirements. Glucose is osmotic, and it will draw fluid and electrolytes from areas of high concentration to areas of low concentration. And the amount absorbed depends on the dialysate concentration and dwell times. How long is it going to stay in there? The higher the concentration, the more the osmotic effect. So insulin can be administered via subcutaneously or directly into the dialysate fluid intraperitoneally. Monitoring is crucial. Frequent self-monitoring of blood glucose or continuous glucose monitors for trends at prescribed times before meals and exchanges in bedtime is essential for effective dose adjustments. So we're going to point to a note here about using CGM later in the presentation on slide 9. If we're looking at administering the insulin subcutaneously, then multiple daily injection regimen using long-acting or basal insulin and short-acting prandial insulin is often preferred for flexibility, and you can manage those glucose fluctuations that happen day to day. The total daily dose is determined individually. We will start with weight-based calculations and titrate from there. And the timing of the long-acting insulin depends on the PD schedule and the risk of hypoglycemia. For automated PD, APD patients, nighttime dosing might be considered. So maybe using a Humulin N or a glargine directly before the PD that's going to go on cycle overnight might be advisable to cover those longer dwell times. The additional doses of short-acting insulin can be used to manage elevated glucose levels that people notice after an exchange with appropriate intervals between the doses. You don't want them hyperconcentrating and trying to inject a rapid-acting analog like Admelog within an hour of each other, because this results in stacking and rebound hypoglycemia. If we're going to administer the insulin via the dialysate, it might provide a more physiological insulin concentration, but requires a higher total dose. And that's because the insulin binds to plastic tubing and there's dilution within the dialysate. And this is the same case as why we change our insulin infusions, because it will bind to the tubing and inactivate the insulin over time. So doses of insulin are typically divided amongst the exchanges, and adjustments are based on glucose levels measured before the exchange or the meals. The dose should be adjusted if the glucose concentration of dialysate is changed. So they change it to a 4.5%, they may need more insulin for that. And adjustments should be made based on patterns observed over several days, not just a single reading, because maybe they had something to eat that day, maybe they exercised that day, maybe they had to take medication that increased their glucose or increased their insulin resistance, which resulted in increased glucose levels. So we do look for at least a 2 to 3 day pattern. Monitor consistently. We want those glucose levels checked frequently in these initial stages of assessment. Identify the patterns, so look for recurring high or low glucose levels at specific times. So if it's after an exchange, or if it's overnight, or after a meal that it's going high, we see a pattern, that's what we can target. Consult the team and look for patterns again and adjust the insulin accordingly. And make gradual changes. You don't want to change everything at once. We won't know which worked. If we change the basal and all the bolus insulins, then we don't really know which one had the impact, and there's more risk for more dramatic changes in the glucose if we change everything at once. And then address hypoglycemia. That's always what we're worried about most. We want to promptly treat a low blood glucose, and patients should know how to recognize the signs and symptoms and treatment of it. Review the insulin regimen and prevent recurrence. They also should have skills on or knowledge about hypoglycemia and driving guidelines, as well as carrying short-acting glucose with them, 15 grams of carbohydrate in either the form of candies or juice, or nasal glucagon Baqsimi. Now, continuous glucose monitors. So I just need to make very clear that CGM is not indicated in patients on dialysis, any type, due to the rapid fluid shifting, and CGM measures the glucose in the interstitial fluid, not the blood. So that rapid shifting is going to impact the accuracy of the CGM results, and there likely will be more of a discrepancy between blood glucose and interstitial glucose. But some patients will use CGM in hemodialysis to identify trends. It's not advised to make treatment decisions on dialysis days, hemodialysis days. So we do have cases where we've allowed in long-term care the hemodialysis days. We would not use the CGM result, but and then the resulting rest of the day and overnight, we would go back to finger poking. And then the day that they're not on dialysis, we would use that for comfort level and that it is accurate enough on non-hemodialysis days. But since PD is typically done daily or multiple times a day, it's really difficult to recommend this, and I've not found data to support it. If the patient decides to use their CGM, they should be instructed that they should finger poke before they make an insulin treatment decision based on that result. They could look for glucose trends with the CGM, but we can't guarantee accuracy in such a fluid shifting state. And then with CGM in PD on the rise, to observe the trends, they do allow for more close monitoring, but they shouldn't be thought of as perfectly accurate in those on PD. And we want to match the insulin regimen to the PD schedule, of course. So if the CAPD is done over 4 to 6 times a day for 30 minutes each, maybe they're taking a rapid-acting insulin just before they do the CAPD exchange. If they're going overnight, then we give them a little intermediate acting like Humulin N or a glargine about an hour and a half or 2 hours prior to the start of APD overnight. and go from there, but adjusting as we go along. What should normal pancreatic function look like? In a normally functioning pancreas, this would be the example of an insulin rise in response to glucose rise. So the brown is the amount of insulin that's put out when a person eats a meal. Their glucose levels start to rise, their insulin turns on, their pancreas lets out extra insulin, grabs the glucose so that it stays within normal targets of about 3.8 to no more than 10. But if someone doesn't have a functioning pancreas, we're trying to mimic what a normally functioning pancreas would look like. Notice as well that the brown line never goes down to 0 because we always need glucose to feed the vital organs. You cannot have a glucose that maintains brain, heart, and kidney function. If the glucose is less than 2.0, we are robbing the vital organs, which is why a critical low is 2.8 millimoles or less. So we never have no insulin in the body because we always need that insulin to carry the glucose into the cell and feed at least the vital organs. That's why we lose dexterity at about the level of 3.9 down to 2.8 and even lower. But if they're NPO, then of course we're going to match that, and we may just need some long-acting insulin to try to keep that glucose carried into the cell for function. So here's one case study. Joanne, she's 68 years old, type 2 diabetes for 11 years, and she has chronic kidney disease. She's new to PD. She's on at 2200, off at 8 o'clock in the morning. And her regimen right now is Basaglar 40 units at nighttime, Admelog 22 in the morning, breakfast, 25 at lunch, 28 at supper, and nothing at bedtime. So she started on PD 4 nights ago, and she comes back to you with these glucose results. So if you want to take a look at each of the times of day down the column, are you happy with breakfast or lunch or supper or bedtime glucose readings? It looks like the tail end of the day, lunch and onwards, is doing okay, but that PD is maybe wreaking a bit of havoc on her glucose levels overnight. And remember, she's not testing at 3 in the morning or giving insulin. So when we have hyperglycemia overnight, we're actually spending more time in a hyperglycemic state, which has more of the damaging effects on the insides of the blood vessels. So we know that breakfast is not in target here. What might be the cause of the high blood glucose at breakfast? Well, if you think about that, it's the PD. She's got this extra glucose going in her all night, every night. So what adjustments could we make? Well, if you think, we could probably give her some more basal insulin, Basaglar, but we're going to need to adjust the Admelog as well. So we need to make sure that because the rest of the day, the lunch, supper, and bedtime glucose levels are within target, that if we increase her Basaglar, which has a 24-hour action for basal insulin, that we're going to decrease the amount of Admelog that she's going to get with breakfast, lunch, and supper, so that we avoid hypoglycemia. And I'd like to thank you for your attention.